Welcome to Weekly Unit 5 and 6. This is a weekly unit that talks about how bureaucracy and money influences the creation and more specifically the implementation of policy. So the objectives for this weekly unit include we're going to take a look at an example of bureaucracy, how administrative entities are created in order to assure policy implementation. And we'll look at a prime example of that. And then we're going to take a little bit closer look at how budgets are used as a policy tool. I've mentioned before that a budget unto itself is actually a policy document. So we'll talk a little bit more specifically about budgets, and then more specifically about how financial bureaucracy is applied to the system in which we work. And then we're going to bring those two worlds of bureaucracy and finance, we're going to bring them together, and we're going to talk about realignment. And we'll talk a little bit about the history of realignment, but more specifically realignment that is unfolding before our eyes today in California. And how historically, when times have been bad in California, there have been wholesale transfers of programs and services to different levels of government. And that's exactly what's happening here. So we'll talk about how that becomes actually a tool of budget policy implementation and the opportunities that provides, because this is something that is going to have a major impact on the system in which you chose to have a career within. So in the last weekly unit, we applied oversight and review and regulatory agencies to the model that we've been developing over the course of this class. And we kind of showed that, over this administrative function in the middle of our model are these entities that do reviews, and they use certain mechanisms like audits and that type of thing to make sure that the administrative entity is properly conducting business in conformance with policy that have come from decision makers or higher levels of government that are, policy directives towards how our mental health system is to operate. So, we talked about these various entities that have been created to do these reviews. And more importantly, we need to remember that those review entities are great sources of reports and data and information around policy analysis, because they're going to have information in some instances all the way down to the county level, and even in a comparative way. So you could look at information from one county versus the other. So these are great sources of information when we're doing policy analysis, especially when we're thinking about how we're going to implement policy ourselves, and more importantly, what can we learn from what other people have done in implementation of policy? What worked well, what didn't work well, and how do we take that and apply it to our specific circumstance and modify that policy so it works for us. So the key part is being able to recommend what that change needs to be so that you could do that yourself there. So we also talked about standards, modifying behavior or providing expectations of behavior within the system, and especially specifically on the professionals that operate within it, whether that's, like licensure through the BBS and that type of thing. And we talked a little bit about managed care, more specifically as a cost containment measure in order to control and contain contributions to the system from primary funding sources, which have a tendency to be higher levels of government. And so in this weekly unit, what we're going to do next is we're going to dig deeper and look more closely at managed care as a prime example of policy implementation, and more specifically the bureaucracy, the bureaucratic entity that's created around that to ensure that policy implementation is compliant with the intent of the policy, and that the services are meeting regulatory requirements, all of that oversight, and then the whole financial piece that goes with that, being able to bill appropriately for the work that's being provided, but assuring that the work being provided is a billable activity so that revenue is maximized and there's no loss of revenue to the entity itself. So managed care, that's a lot of what that's all about, and it's a prime example of bureaucracy related to policy implementation. And so when we say managed care, what are we really talking about in managed care? The typical model is an administrative organization that has contracts with specific providers, and in order to contract with the administrative entity, you have to agree to certain payment reimbursements and limits for costs for providing a particular service, but in return for that you get the volume of the clientele. So that's a prime example of managed care. And so think about it as an organized care network. Now, historically here, the most common type of managed care that's prevalent in our society today are organizations known as HMOs and PPOs. So an HMO is a health maintenance organization. Its primary responsibility is to maintain contracts with various providers in order to provide a certain level of services for the people that pay into that particular insurance program. And then the administrative entity is responsible for auditing those costs and making sure that those providers that they contract with are only charging them for the services that they actually provided, as well as the providers themselves have to agree to these rates that are set forth in the contract that they're going to be paid for the services that they provide, which is typically less than what they would normally make, but that's made up in volume because through the contractual relationship, the provider's also receiving access to a network of clients as well. And PPO just being a variation on that, but being a preferred provider organization. In other words, there's a little bit more flexibility in the consumer in choice. In other words, you don't necessarily have to only go to the doctor that is attached to the HMO. You may actually pick a doctor that's more familiar to you, and they just happen to be able to have access to a contract for the insurance company, and but there's just more variety. That's really the difference between the two types of basic organizations as we know them today. And so even when you think about for those of us that are working in a public community health system, whether it's at the county level or through a federal organization or through a private organization as well, we see aspects of managed care in all the work that we do because we have to keep specific notes and charts and account for our time and make sure that we're able to appropriately code for the services that we provide. And if we can't code, then we have to pick codes that ultimately turn out to not be billable. And that's a prime example. So the local mental health plan, the MHP mental health plan, is a county level managed care function for local government, that what counties have to provide on behalf of Medi-Cal over the local providers within their jurisdiction. So managed care typically looks at controlling access to the healthcare system, maintaining a level of quality, but at the same time, trying to drive people towards less expensive services, which is the third component, containment of costs. So let's start with costs. There are typically three types of costs in a managed care system. There's prospective, concurrent, and retrospective. So prospective means that in order to be able to provide the service, it has to be approved. So quite often for us, the primary example of that has been, we go in and we see our primary care doctor, but then we need to see a specialist. Well, to really get access to the specialist, you have to have a referral from your primary care doctor. That's just an example of how a managed care entity enforces policy on the medical provider to ensure that costs are contained and that people aren't going straight to specialists without first being seen by the less expensive service, which is the primary care physician. And then the example of concurrent costs are that cases are managed. In other words, there may be an array of services that are being provided, but they're being provided in a case managed way, not individually and not apart from one another. And then retrospective, that in managed care, what that really means is we're going to go back and we're going to audit and we're going to look at the costs that were charged out for certain services, go back maybe even all the way down to the chart level to make sure that the service that was actually being provided to that beneficiary at that time was a service that was, number one, eligible to be billed against the funding source, but number two, that the person providing that service was competent and either appropriately licensed or had the proper education or credentials in order to be able to provide that service to begin with. And if not, then why wasn't it charged to a paraprofessional classification or something like that? So what you're going to do now is you're going to close this particular presentation and you're going to move to the next, which is actually a link to a video clip, and then watch that video and then come back and open up the next part 2 of this particular PowerPoint.